Hey guys, it's Olivia. Welcome back to your endocrinology chapter. In this section, we'll be going over our last cause of adrenal insufficiency, that is tertiary adrenal insufficiency. And you're probably sick of hearing me go through this pathway at this point, but humor me one last time. So we're starting out in the hypothalamus here. Our hypothalamus in your brain is going to be releasing CRH. CRH will travel to the anterior pituitary, which will release ACTH, which will travel to the adrenal cortex and stimulate your adrenal cortex to release corticosteroids. Now, in tertiary adrenal insufficiency, this is going to be a problem that's occurring at the hypothalamus. Remember, that is the third gland up from the bottom gland in our pathway. Adrenal cortex is the first gland, anterior pituitary is the second gland, and we, of course, are talking about a problem with the hypothalamus in tertiary adrenal insufficiency. And tertiary adrenal insufficiency is usually only caused by one thing, which is abrupt cessation of exogenous steroid use. So someone who's been on steroids for a while, they suddenly stop, they don't taper off. This is actually the reason why whenever we prescribe steroids, we prescribe a taper to stop them rather than just stopping cold turkey because it can cause adrenal insufficiency. But if you do stop steroids abruptly, you can cause this hypothalamic dysfunction in which your hypothalamus up here in the brain is not secreting CRH. CRH is not traveling to the anterior pituitary, so the anterior pituitary is not secreting ACTH. And that will lead to a decrease in cortisol because there's nothing to stimulate the adrenal cortex down here to release that cortisol. This is going to present with all of your classic signs of cortisol insufficiency, so all of your glucocorticoid symptoms. You're not going to have any mineralocorticoid symptoms with this presentation, so you won't have any skin hyperpigmentation or any of those symptoms of low aldosterone, but you will have decreased cortisol, and that will lead to your presentation of weakness, fatigue, orthostatic hypotension, muscle aches, hypoglycemia, weight loss, and GI symptoms. So you might have decreased androgens with this presentation, and that will lead to depressed mood, decreased energy, decreased concentration, irregular menses in female patients, and or erectile dysfunction in male patients. The diagnostics for tertiary adrenal insufficiency should make sense to you. So we'll have decreased ACTH because we have decreased CRH stimulating our anterior pituitary, so we're going to have decreased release of ACTH. We're going to have decreased cortisol. That is the definition of adrenal insufficiency. And then we're going to have normal aldosterone, as we mentioned above, and normal potassium because we don't have any deficiency in aldosterone. We're still able to regulate the kidney's retention of potassium. Morning cortisol levels are going to be decreased, similar to most of our causes of adrenal insufficiency. Our morning ACTH is also going to be decreased. We just talked about that. And then for our ACTH stimulation test, our ACTH stimulation test should actually stimulate the release of cortisol because the problem here is that we're having hypothalamic dysfunction. We're not releasing our CRH, but there's nothing wrong with our adrenal cortex. So if we stimulate our adrenal cortex appropriately with some ACTH, it should be able to release that cortisol. Management is just going to be the replacement of what we lack, so glucocorticoid replacement. And a special note here, for patients who do require glucocorticoid replacement, this is going to be different amounts of glucocorticoids depending on if they're perfectly healthy, living their normal lives. It'll be a pretty standard dose. But if this patient is experiencing a stressor such as a recent illness or they're hospitalized or they have a surgery, normally your body would increase the amount of cortisol released in response to a stressor, right? It's one of those fight or flight hormones. But for patients who have adrenal insufficiency, they can't do that on their own. So we as providers have to stimulate that increased release of glucocorticoid, and we should increase their glucocorticoid replacement in times of stress. So if you ever hear stress dosing of steroids, that is basically what that means. We are increasing their steroid dose to stimulate what the body would normally do in times of stress. And now that we've gone through all of the different types of adrenal insufficiency, let's review by walking through this table. So primary adrenal insufficiency is going to occur at the level of the adrenal glands. This is something wrong with your adrenal cortex. Secondary adrenal insufficiency, by contrast, it occurs at the level of the anterior pituitary. We are marching up this pathway. And then tertiary adrenal insufficiency, as we mentioned in this video, is going to be a problem with the hypothalamic axis. So our hypothalamus is going to be affected, decreasing the release of CRH. Now, I've illustrated all of the different hormonal changes and diagnostic tests between each of these types of adrenal insufficiency. But the ones I want you to really pay attention to are the bolded ones, because those are what's going to help you differentiate between different causes of adrenal insufficiency. So decreased cortisol and decreased androgens are going to be ubiquitous to all of these pathologies. They're going to be decreased across the board. That's not really helpful for you to differentiate between different causes of adrenal insufficiency. What is going to be helpful, however, is that aldosterone is going to be decreased only in primary adrenal insufficiency. Similarly, ACTH is going to be increased in primary adrenal insufficiency. That makes sense, right? Because the entire pathway is backing up behind this problem at the adrenal cortex. There's no negative feedback. So we're going to see very elevated levels of ACTH in primary adrenal insufficiency. However, in secondary and tertiary adrenal insufficiency, ACTH will actually be decreased because we either have a problem with the pituitary in secondary where it's not making ACTH, or we have a problem with the hypothalamus in tertiary where we have no CRH to stimulate the anterior pituitary to do its job and make ACTH. This increase in ACTH in primary adrenal insufficiency is what's going to lead to the increase in MSH that also is made by the same POMC gene. That is what's going to lead to the tan and copper skin in primary adrenal insufficiency only. CRH is also going to be increased in primary adrenal insufficiency. Everything behind the cortex is backing up and building up in primary adrenal insufficiency. But it's going to be an important test for you guys to differentiate between secondary and tertiary adrenal insufficiency, more importantly. It's one of the only hormones that is different between both of these etiologies of adrenal insufficiency. And it's going to be increased in secondary adrenal insufficiency. That should make sense because everything behind the level of the anterior pituitary is backing up or building up in secondary adrenal insufficiency. However, it is going to be decreased in the case of tertiary adrenal insufficiency. That's because the hypothalamus is not making enough CRH, and that is what's causing the problem in tertiary. So this difference in what's happening with CRH is going to be a key way for you guys to differentiate between secondary and tertiary adrenal insufficiency. That's a nice segue into the diagnostic labs that you can use to distinguish between these types of adrenal insufficiency. So AM cortisol, that's going to be decreased across the board. Morning ACTH is going to be elevated only in primary adrenal insufficiency, as we just talked about, with the unique elevation of ACTH in primary. You will see no response with the ACTH stimulation test in primary adrenal insufficiency. That's because the adrenal cortex is broken. It can't listen to ACTH even if it wanted to. But in secondary and tertiary, where the problems are higher up in this pathway, but the adrenal cortex itself is actually intact, then you will see a response to the ACTH stimulation test, and that will be increased cortisol. And then finally, to differentiate between secondary and tertiary adrenal insufficiency, you can use the CRH stimulation test. If the anterior pituitary is functioning and it's not broken, then it should respond to CRH and release ACTH. That's exactly what happens in tertiary adrenal insufficiency, where the problem was at the hypothalamus and we had lack of CRH, but the anterior pituitary is still functioning. If this is an anterior pituitary pathology and the problem is that the anterior pituitary, for whatever reason, just cannot secrete ACTH, then no amount of CRH is going to induce it to do so. And that is why in secondary adrenal insufficiency, we will see no response to the CRH stimulation test. Finally, I would highly recommend paying attention to some of these key parts of the presentation for each type of adrenal insufficiency. So primary, type 4 renal tubular acidosis, tan and copper skin. Secondary, anything that causes a pituitary infarct should be in the question stem, notably Sheehan syndrome or some type of damage to the brain. And then tertiary, this is pretty much only caused by recent steroid discontinuation. So look for any reason that a patient might have been taking steroids, something like an autoimmune disease, a recent asthma exacerbation, something like that. So to quickly recap, 3 simple steps that I like to go through when approaching adrenal insufficiency question are: number 1, look at the morning cortisol. If the morning cortisol is decreased, that means we are indeed dealing with an adrenal insufficiency and we should work through the rest of this problem as such. The second step is to look at your morning ACTH. This morning ACTH is going to be helpful because if it's increased, we can be done with the problem already because we know that it's a primary adrenal insufficiency. If the ACTH is decreased, however, that means we're not dealing with a primary adrenal insufficiency, but it could be either secondary or tertiary. Then we're going to proceed to our CRH stimulation test. If we get no response to the CRH stimulation test, that means that this is a secondary adrenal insufficiency. If we have increased ACTH in response to the CRH stimulation test, however, and we also had a decreased morning ACTH, that means that we are dealing with a tertiary adrenal insufficiency. That's a quick and dirty way that I like to approach these problems. How do they ask you about this on a board-style question? Well, something they might ask you is a 26-year-old man presents to his physician for 3 weeks of decreased energy, difficulty obtaining an erection, and occasional dizziness when standing. The patient has a history of ulcerative colitis and was recently treated for a flare, but no other medical condition. Morning cortisol levels are decreased and morning ACTH levels are also decreased. What is the most likely cause of this patient's presentation? So we have a patient with decreased energy, difficulty obtaining an erection, and occasional dizziness. Certainly that could be orthostatic hypotension due to decreased cortisol, decreased energy, and erectile dysfunction due to decreased androgens. This is definitely a picture of adrenal insufficiency. Then they tell us that we have a decreased AM cortisol, so we can start to work through our adrenal insufficiency steps. It tells us that we have a decreased ACTH, so we know that we're not dealing with a primary adrenal insufficiency. The question doesn't give us the response to the CRH stimulation test, however. And that's going to be pretty common. On step 1, they may or may not give you a clear pathway to this answer. We're going to have to look back at the question stem to guess which is more likely, damage to the pituitary or recent steroid discontinuation. The question stem did tell us that this patient has ulcerative colitis and recently had a flare-up. You should know that ulcerative colitis can be treated with immunosuppressants such as steroids. If this patient was recently treated with steroids and did not do a taper but just discontinued their steroid medication, this could certainly be a cause of tertiary adrenal insufficiency. And that is the answer that I would look for on step 1. Now, I hope this video was helpful, and I'll see you next time.